Good afternoon, everyone, and welcome to the March KPQC Learning Forum. We are going to have a great presentation today by Bree Fallon, and I'm going to turn it over to Carrie to get us kicked off.
Hi, everyone. If you could please make sure you just put your name and agency in the chat. That's why we've left that slide up on the screen for you so that you guys, I say, get credit for being here, but we're also just very excited to see who joins us. So make sure you pop that in, and then I will get us going. I think we realized as a team that we have several new facilities and new people who've joined us. So we wanted to make sure that we took the opportunity to do an introduction that we've taken for granted for the past year or so. So I'm Carrie Smith. I'm one of the KPQC co-coordinators, along with Tara Strada, and then Jill Nelson's our KDHE and KPQC maternal and perinatal consultant. And we love our acronyms. So as we just throw letters out there, just bear with us and don't ever hesitate to ask, because we love to throw out our letters. This year, we were fortunate enough to have Michelle Black join us, and then Tiffany Burrows, who is like our hero in all things making our processes work. So we just wanted you guys to have the faces that go along with our team. At the same time, I wanted to make sure that you guys were all familiar with the KPQC Advisory Committee. For those of you who will be joining us for the in-person April meeting, you'll be having lunch with the KPQC Advisory Committee. They'll be there. And so just to show you a few of the faces ahead of time is always lovely. We always start off our learning forums with what we call our rapid responses, things that are going on throughout, not just the state, but the country, that we want to make sure that you guys are aware of. And I'm sure many of you have heard about all the measles outbreaks that are happening. And I wanted to make sure that if you hadn't, we brought it to the forefront, just the importance of talking to our patients on immunizations, how it can impact our moms, as well as not immunizing our babies after delivery too. So just make sure you guys are aware of and having those conversations of the importance of these our patients, because it's incredibly, incredibly important. And we've also had cases, I don't want to say cases, I do know of one case in Kansas too. So I know a lot of people are highlighting the fact that Texas and New Mexico are our primary. Like it says like 201 of the cases happened there, but we have also had one in Kansas too. So a little too close to home. With that being said, the CDC put out an emergency preparedness response on March 6th. Really just emphasizing the importance of getting the information out there on vaccinations as well. We are closing up our enrollment for this hypertension bundle, and I'm excited to let you guys know that we have 35 birthing hospitals. 4 of those are new birthing hospitals that were not 4th trimester initiative enrolled. And I'm doing huge cartwheels to celebrate the fact that we've got 11 non-birthing hospitals throughout our state enrolled, with 2 more I've got my fingers crossed are pending to join us. So just to give you a picture, I'm a visual person, just to give you a picture of where we are located around the state. You will see all of the red hearts that you see here are our birthing facilities around Kansas. And then our blue hearts here are our non-birthing facilities. The 2 greens are the 2 that I'm still hopeful I'm going to get on board, and I refuse to delete them until I'm confident it's not happening. But just excited, you guys, excited to see the reach that we have across our state to really be involving so many of you that are out there doing the work on the front line, taking care of our patient population, and the importance of understanding the vast differences that happen throughout the state in resources, accessibility, all of that. I just want to celebrate this moment. So what happens next? We've closed enrollment. Now we're in quarter 2. Officially will start April 1st, and that is where we start a lot of our education. Our post-birth education actually begins this Friday, and the registration for that will go out either this afternoon or tomorrow morning. But it'll come out from Tiffany on the KPQC email address. Where we are also working is on the public health side, getting the education out to our community organizations as well. And then your role is to make sure that you're getting education out to your patients. Once you have taken the post-birth training, or if you've already taken it and embedded that process in your hospital, education should be happening with the patients in order for them to understand those very important maternal early warning signs. And with that being said, we showed this slide last month, but these are the dates and times that post-birth training will happen. And again, that registration will go out when Tiffany sends out the recording of today's learning forum. Just a quick synopsis of what quarter two's expectations for the enrollment will look like. Again, I talked about post-birth education, that fabulous in-person meeting that we'll have April 23rd. This is a mandatory meeting for our birthing facilities. And we are not making it mandatory for our non-birthing, but would love for them to be able to join us in hopes that if we can't, that we will put together a virtual option for them, just because we understand that a lot of what we will be talking about in that meeting may be encompassed around what's pertinent to our birthing facilities. And then we may be able to better meet the needs of our non-birthing facilities. With a separate conversation, however, I'm hoping that if we can get our non-birthing facilities to join, what a great collaboration that will be for you guys to talk about barriers in transport, or just the importance of collaborating with our outside EDs to get good patient care and the continuity that's happening from facility to facility. At that meeting, we will also go over our ACOG algorithms, our CMQCC protocol or algorithms. You guys will all come to the table with your protocols and then have that conversation of what's best practice and what we should be implementing out there for our hypertensive patients. Covering a little bit more in depth of what Bree will be talking about today, but hypertension as a whole, and then what that looks like for our providers and nurses, who's diagnosing, who's treating, et cetera, et cetera. And then I say the dreaded conversation. I'm a data nerd and I love data, but having been on the inpatient side, I also know sometimes how difficult it can be to gather data and do the polls and submit data. So do know that I feel you. There will be an email coming out at the end of this week from Tara Stroda about more information related to our data collection. And just know that the goal is for it not to be as intimidating and dreadful as it may feel. So hang in there with us. Just to give you an idea, this is our model of care. Where are we in this process of on the model? What we're discussing, it's that identify hypertension, go over our protocols so that our facilities know how to adequately treat. This is where we'll be in quarter two on covering this. And then, like I mentioned with your data, baseline data that we've been trying to get from each of you, everyone that's enrolled should have gotten an email from Tara that looks exactly like this. It says, now that you're enrolled, here's the next steps. Within that are two links, the breastfeeding protocol and the baseline facility and reporting period data collection piece. If you are having issues with filling out the breastfeeding protocol, because I did submit it via Google survey, and I know some hospitals have walls that block you from opening those, just reach out to me and let me know. I can send it to you in PDF form. I've done that for a couple other facilities too so far, but I really want to make sure everyone gets in their data for me. And then the other link, that facility and reporting period link, is just your baseline AIM data. Again, Tara will talk to you more about data collection this Friday, but I'm really hoping that I can get baseline data from everyone in as soon as possible. More about the identification phase, just a recap of what we sent out and talked about last month as well. There are some links for watching how do you appropriately take a blood pressure, toolkit resources from CMQCC about improving healthcare response to hypertensive disorders in pregnancy, and then just additional resources. So we really are, I think you'd be surprised at how we take for granted that we think everyone is checking blood pressures the same, that they're using the right size cuffs, that they have the patient sitting in the right position, and I can attest to you it's not happening. And Bree will shake her head right there with me. It's definitely not happening. So as fundamental as this may seem, we really are taking this back to the basics because we have some pretty big pieces that are missing within our hospitals on how to do this appropriately. So hang in there with us as we remind everyone, fundamental is what we're supposed to be doing in order to accurately identify that we even have hypertension before we move forward with what does that look like and how do we treat it. And I'll skip this slide because I know Bree's going to talk about this as well. articles to share. I love to share with you guys any articles that I come across in between our learning forums. And this was a February 2025 article that just highlighted that women who are exposed to hypertensive disorders in pregnancy and their first delivery have a significantly increased cause-specific hazard ratio of AFib compared to their unexposed counterparts. So I just wanted you guys to realize, as we talk about comorbidities and issues that happen related to hypertensive disorders and pregnancies, this is just another example of things that we're seeing with our pregnant patients who experience this. In addition to that, another article that came out is that risky pregnancies driven by cardiovascular risk factors remain common for Native women. So the data suggests that complex interventions are needed to help care for our Native Americans or Alaska Native to address both risk reduction and effects of structural racism. We've definitely had this conversation before, but it's just one more highlight, especially within our state. We know that we have areas where that patient population is very prevalent, and what can we be doing to make sure that we are identifying and caring for appropriately. And then I also wanted to share out with you that the Kansas Birth Equity Network is presenting a Keeping Our Families Safe Black Maternal Health event on April 19th from 10:30 to 2. And you guys, this presentation will be sent out, but you can scan that QR code to register. It's a great opportunity to be engaged in the work that's happening with our community partners throughout the state of Kansas. So with that being said, and I intentionally wanted to really blow through that because I wanted the majority of this time to be available for Bree, I want to take this opportunity to introduce her. Bree Fallon has been in the field of OB for over 20 years. She had the opportunity to participate in a variety of different roles, including bedside nurse, clinical educator, high-risk obstetrics flight nurse, legal subject matter expert, and most recently, she's a perinatal risk manager. She's had the privilege of sitting on the Kansas Maternal Mortality Review Committee for a number of years and presented on a variety of different topics on both the local and national level. Bree remains in constant pursuit to learn and contribute to the highest level of care our healthcare teams can collaboratively provide to our OB patients and the families we serve. And selfishly, Bree happens to be a very dear friend of mine. So I'm super excited to have her here with us today and grateful for her knowledge and willingness to share with all of y'all. So at this time, I'm going to turn it over to Bree.
Well, thank you, Carrie, and thank you for having me, everyone. Yes, I'm Bree Fallon. It's nice to see you all on the call. And just, Carrie had asked that I speak about preeclampsia and hypertensive disorders of pregnancy. And I'm so passionate about it. And I think part of the reason is because when I was onboarded as a new grad nurse, I did not understand all of the pathophys with preeclampsia and the other hypertensive disorders of pregnancy. And, it was probably about 10 years into my practice where I went to a conference and I heard someone present on the pathophys of preeclampsia, and it all clicked. And I understood why we watch for different symptoms and how they interplay with one another. And really a lot of research has been coming out in the last 10, 20 years about preeclampsia and the treatment of such. And so it's really, a wonderful topic to talk about. And I don't know how I can only talk about it for, 45 minutes, but I'm going to try. So the objectives that Carrie wanted me to cover, I have them on the next slide. We're just going to talk really about hypertensive disorders of pregnancy, reviewing the pathophys of preeclampsia and how it presents in different patients. We'll talk a little bit about the maternal and fetal complications that are associated with preeclampsia, and then just kind of talk about some of the resources that are out there available to all of our clinicians. So with that, we're going to dive in to the pathophys. So the maternal placental fetal circuit, it's really remarkable when you think about it. And this is very basic, but you have a mom's heart and a mom's body who's doing the work for two people during pregnancy. And so there's a lot of adaptations that happen to the pregnant body. And really, with this circuit of vasculature, it involves the developing fetus, a growing placenta, evolving decidua, and the maternal cardiovascular system. And the fetus and the placenta has some contributions that impact mom, estrogen and progesterone, the placental growth factors and its receptors to maintain this angiogenic and anti-angiogenic balance to mediate this adaptation for this really dynamic period of this person's life to carry another human being. Trophoblasts go in and mediate this remodeling in spiral arteries to create this system of low resistance and high flow. So you have all this extra blood volume, and the blood vessels really do accommodate to and relax to accommodate that extra volume and create this low flow. So low pressure, high flow. Whereas the maternal cardiovascular system impacts the developing fetus, and this increased output and decreased systemic vascular resistance supplies so much oxygen that's sufficient enough to grow another human to this developing fetus. So that's real brief, but it's just, when I think about it, every time I think about it, like every pregnant person can accommodate another human or two or three, you know, if there are multiple gestations, and the adaptations of their body to do so are really remarkable. Now, at any course in these adaptations, if we have some issues, that's where perhaps we can see things change. But we'll talk about that in a minute. So anybody who knows me knows I love a good analogy. And also spring is my most favorite season. So on the next slide, I have just a picture of a hose and a sprayer, which Carrie, can you, yeah. So I don't know about you guys, but just like being outside in my yard, I love my flowers, I love my vegetables, I love watering my new tree. Flowers are all coming up. And so when I think about this, you know, in a normal pregnancy, there's all this accommodation. There's a doubling of the uterine artery and over 20-fold increase in placental perfusion. And it results from that increased cardiac output and all of those remodeling, those trophoblastic remodeling on those uterine spiral arteries. And it changes them into large, low resistance vessels. So the spiral arteries in the uterus, they remodel to allow for high flow and low pressure. And the spiral arteries do this for the fetus to get all this extra blood flow and enhance the perfusion all day, all night long. And it's similar to our high flow rain shower garden hose. I think about, that's my favorite thing to spray my trees and my flowers with, because it really bathes them in all this extra volume and saturates them in plenty of water so that they can grow and get their nutrients and really be successful plants. So healthy vasculature in pregnancy is able to accommodate this extra blood volume and pregnancy and decrease systemic vascular resistance. So usually we do, in most of our patients, see a decrease in blood pressure in our pregnant patients. And that's to accommodate all of this extra blood. So this garden hose looks like it's in pretty good shape. It's able to transport water throughout the yard, out to the corner of my yard, the trees, every place. So it looks pretty good. So that's what I'd like, you know, to be watering my lawn with. But on the next slide, I have some other equipment. So the first slide, people have probably seen this before. It's a cross-section of a spiral artery. So, you know, during preeclampsia, those myometrial arteries, they don't adapt. And there's a lot of different discussions on why they don't adapt. But what we know is they don't. They're not able to. The spiral arteries don't remodel as effectively. And so they have this really shallow invasion into the decidua. And the blood flow to the placenta, it's just not the same. It's not bathing the placenta, it's just limited. And so there's a poorly perfused placenta at the end. And this condition is kind of chronic, and the placenta, when it's not perfused well, just like any tissue that's not perfused well, gets a little angry and has some ischemia to it. And so this releases mediated factors and cytokinins into the maternal circulation, which damage the maternal endothelium. And I want you guys to all, no matter where you work, dig deep and think back to vasculature 101. Endothelium, that inner lining of the vasculature. And so when this is damaged throughout the maternal vasculature, these cells become dysfunctional and they lose their ability to maintain proper vascular function. So, you know, these cells play a really crucial role in regulating blood flow, blood pressure, vascular permeability, and this endothelial dysfunction also can lead to thrombosis and hyperinflammation. So you think about that in a garden hose. And so the nozzle, I would compare to the spiral arteries. Not ideal for, you know, high flow, low pressure delivery. The narrowing of the spout just can't provide as much volume as our lovely rain shower head, right? And also, it's a lot of pressure, right? And then I think of a soaker hose when I think about the vasculature of a mom. You know, everybody's familiar with a soaker hose. It leaks out and it has a great purpose if you have foundation issues. But the vasculature of a mom who's had this endothelial damage really leads to these leaky, damaged vessels. And it's increased capillary permeability. There's abnormal blood vessel function, and it increased the platelet activation and consumption. And you think about what the end of the pressure is like at the end of the soaker hose. It doesn't have as much pressure and you don't have as much perfusion. So, meaning the lining of these blood vessels is damaged. We have an inability to relax. We can't dilate and relax, so we have that constriction, further reducing our blood flow to the organs. And the high pressure inside really causes that vasculature to leak. So at the end of the day, we have crummy vasculature in these patients that has damaged endothelium and an inability to really supply the placenta with a good volume at low pressure to allow for optimal growth. So that's my analogy, and we'll dive into that, you know, in the next couple of slides. So there's different hypertensive disorders of pregnancy. I have been lucky enough to sit on the scientific advisory panel for the American Heart Association. And it's really interesting to me because there's a couple MFMs, but the majority of the team is cardiologists. And it's really interesting how they want an OB nurse's help and thoughts on preeclampsia and how they present postpartum, because they managed hypertension the majority of their practice, and they're not as well versed in these obstetric and hypertensive disorders of pregnancy. So that's been really kind of eye-opening. But when we talk about the different disorders, we're going to mention all of these, but all hypertensive disorders, they're all a little different. Preeclampsia is a systemic syndrome that occurs during pregnancy and up to 6 weeks postpartum. That's the leading cause of maternal and neonatal morbidity and mortality worldwide. So, you know, this is something that we don't see here and there. We see it so frequently, and I feel like we've seen a lot more of in recent years, just as our population has become more high risk. So if you want to go to the next slide for me, Carrie. So real quick, just to differentiate the difference between these three, we have chronic hypertension. So chronic hypertension is the patients who've already been diagnosed with hypertension prior to pregnancy. But I don't know about you, but the majority of patients that I know perhaps have not been getting great provider care. They haven't been going to the doctor because they're not sick. And the first time they really have an experience with the healthcare setting, a lot of times is for their first pregnancy. So that's also why we say if they have hypertension on their first visit or prior to 20 weeks, you know, as I mentioned earlier, the pregnancy should really be, the vascular should be accommodating this pregnancy, and we should see lower pressures in pregnancy. So if someone comes in at 12 weeks and their pressures are elevated, that would mean they have chronic hypertension. So a lot of people get diagnosed in their first trimester with chronic hypertension that they haven't been diagnosed with before because they just haven't seen a physician or had a need to see a physician. So on some terminology, gestational hypertension is your elevated pressures after 20 weeks. After 20 weeks or up to 6 weeks postpartum. And so these are elevated pressures of either 140 systolic or 90 diastolic on 2 occasions more than 4 hours apart. This is what we used to refer to as PIH. pregnancy-induced hypertension. PIH is no longer a term that I hear it thrown out all the time, but we don't use that anymore. It's not in the literature. So when ACOG came out with their hypertensive in pregnancy disorder task force in 2013, it's not mentioned anywhere. So just keeping you guys cool and in with the new verbiage, we don't use PIH anymore. Gestational hypertension is the correct word. Also, on the third column there, I have preeclampsia. And notice there's no mild preeclampsia. And the reason they did away with the term mild preeclampsia is because it denotes that it's not that bad. So when they redefine some of the terminology, they now have preeclampsia or preeclampsia with severe feature. Because preeclampsia, it's a hypertensive disorder of pregnancy that can cause multi-organ dysfunction with placental dysfunction, which I'll talk about that more on the next slide. But that's not mild. There's nothing mild about that. And it can always risk the chance of escalating into preeclampsia with severe features. So I do want to mention that elevated pressures can begin up to 6 weeks postpartum. So that's important for you guys to know, because that means you can have a healthy pregnancy or a woman with a healthy pregnancy who didn't have any complications coming into the ED or urgent care with symptoms of preeclampsia that weren't ever diagnosed. And so it could be onset of preeclampsia after delivery, which that's kind of, I think a lot of people in the obstetrics setting are familiar with that. But to some of our friends who work in ED or in non-birthing facilities, that might be new news to you. So that's really good, because that way you are able to identify these patients and get them plugged into where they need to. So let's go to, oh, and one more thing I want to mention on this slide is, I don't have it on here, but a patient who has chronic hypertension and is well managed, controlling their blood pressures and is doing pretty well, who all of a sudden experiences, increased need of medication or having symptoms during their pregnancy, that patient would be said to have chronic hypertension with superimposed preeclampsia. So they have chronic hypertension, and that does put them at a higher risk of preeclampsia. But when they start needing additional support or having symptoms and they're fine when they're not pregnant, that's superimposed preeclampsia. So those are kind of the different terms that we use, and we'll talk about a couple more in a few slides later. But, so on preeclampsia, what do you need for preeclampsia? As I said, it's a hypertensive disorder. You got to have an elevated blood pressure of greater than 140 or equal to systolic, or greater than 90 or equal to diastolic. Don't have to have both, but you got to have one. And really, it's paired with, traditionally, you'd think we have to have protein in the urine. If they have high blood pressure and protein, they have preeclampsia. If they don't have protein in their urine, you can still have preeclampsia. So that's why they really changed the nomenclature and said, in the absence of proteinuria, if you have any end organ damage, that is true to be preeclampsia. So when you think about what's going on here, I want to go back to that Stoker hose. We have increased vascular permeability, cruddy Stoker hose, and so we have these leaky vessels. So do we see this in our patients? Think about your patients who, are typically preeclamptic. You think about their puffy hands, think about their ankles and how their feet aren't even fitting into their shoes anymore, and that pitting edema. So yeah, we see this. We even have periorbital edema sometimes on some of these patients because that leaky vasculature. So the fluid is leaking outside the vasculature because those blood vessels are damaged. And if you dig really deep back to biology, you might remember where fluid goes, protein follows. That's Starling's law. So where fluid goes, protein follows. And so frequently we see proteinuria, protein being spilled out into the kidneys. And so you have this elevated pressure with damaged vasculature, and we also have proteinuria. And so there's your preeclampsia. Now, in the event you don't have proteinuria, any one of these symptoms is indicative of end organ damage. So, and we'll talk about those more on the next slide. But end organ damage, those are things we consider severe features of preeclampsia, because it's not just the vasculature at this point. Your organs are being affected. So those are severe features. So again, I want to mention this can happen after 20 weeks. We typically see, after 20 weeks, sometimes they're starting to differentiate between early onset preeclampsia and a later onset. I think everyone who's been in obstetrics has taken care of patients who have been diagnosed 24, 26 weeks. And an earlier gestation is associated with a higher morbidity for mom and also for neonates because delivery is indicated. So when we have to deliver a patient because of a preeclampsia at 26 weeks, that baby is going to have a higher morbidity and mortality risk just because of the prematurity associated with it. Also, up until 6 weeks. So where I typically, I like to use different stories. I had a sister-in-law who she had a baby a couple weeks ago, went into the ED because she just had this horrible headache and she wasn't feeling like herself. She just was tired and could not get rid of her headache. So the ED clinician said, well, your blood pressure is 148/88, which of course seems not that high, right? If you work in the ED. But then she says, well, usually it runs about 100 and, over 60. On further inspection, she says, and I just can't sleep very good because every time I lay down, I feel so much fullness in my chest. I just can't seem to catch my breath, but I figured it was my milk coming in. So she's got a severe headache. She's having shortness of breath and elevated pressure. So she had hypertension with 2 symptoms of end organ damage. So she did have preeclampsia with severe features. So, things that can be attributed to, well, she's tired. She was up all night with the baby. Her milk came in. Those are things where you really can be a detective and say, I'm really concerned about this lady. I think she needs some additional testing. We need to watch her. So let's talk a little bit more about the preeclampsia with severe features on the next slide. So any severe feature would be end organ damage, or the first thing on there that ACOG has is a severe range blood pressure of either 160 or greater systolic or diastolic of 110 or greater. Now, friends, especially in the ED, I know you've seen higher pressures than that, and you don't typically worry about them because 160 we see. But now, in a patient who's normally normotensive, this is too high. And so the reason they've made this severe and worth treating with an antihypertensive is because this puts patients at a higher rate of stroke. So if we don't treat these pressures, either 160 or greater systolic or 110 or greater diastolic, these patients can have a stroke. And so that is definitely an increase in morbidity. So they started finding that we really need to get these patients treated. And I know Carrie's going to go into treatment algorithms with you in a few weeks, which is great. But ideally, we want to treat these patients within an hour. I mean, as soon as possible is the goal, but bare minimum in an hour. These patients, you can give them IV labetalol, IV hydrolysine, or on some of these patients who are very hypertensive, their vasculature is really difficult to establish an IV access site. So you can even give them pionifedipine. So just while you're establishing access. So that's all I want to say about that, but worth mentioning. The other features that are severe are the evidence of the end organ damage. End organ damage. So think back to that picture of the soaker hose. Think back to all of that leaky vasculature. And again, where fluid goes, protein follows. So we have not only protein maybe spilling out into the urine, but we also have a decreased perfusion to the kidneys. So on these patients, they might present and say, I can't leave you a urine sample. I haven't been able to pee all day. That would be concerning. Pregnant people should pee a lot, right? But that decreased perfusion, these are patients that we really watch their output hourly and really make sure that their kidneys are functioning. So another severe feature is the thrombocytopenia. So low platelets. Why? Well, you think about that endothelial dysfunction and how the platelets are activated and consumed, and they get to a point where they're gone. And so patients, I remember having a patient who just started complaining of some, a headache, a low-grade headache, and we treated her. She was on antepartum. She had been having elevated pressure is not severe. And she said, yeah, I'm really not feeling good. I just feel poorly. And we had drawn labs that morning, and her platelets, I think, were around 120. And we drew them at 3 o'clock that afternoon, and they were in the 40s. And it's her platelets had been activated and consumed, and they dropped very quickly. So I think that's of note, because platelets, that's your coronary disorder, you know? And so when we have patients who are about to deliver or need to go to C-section, or perhaps have problems with their placenta, we should be concerned in the back of our mind if we don't have enough platelets, or would be concerned about that. So also, you know, your poor perfusion to organs can lead to your impaired liver function. You can have abnormally elevated liver enzymes, or persistent right upper gastric pain. And so a lot of times I feel like the patients who have complained about it, I just don't feel right. I'm kind of nauseous. And it's kind of vague. But when they have it, you listen to them, you know, maybe give them some Pepsid, make sure it's not indigestion, but if it doesn't go away, that's upper quadrant pain, and we should pay attention to that. How else are our blood vessels leaky? Well, you think, where else can they leak? What about in the lungs? So in the lungs, that leaky vasculature can actually lead to non-cardiogenic pulmonary edema. And so this is going to affect your mom's ability to oxygenate herself and her baby. And really, you know, most women do sat pretty high, like 99, 100. So a woman who's sat in 95 or 94 might have pulmonary edema. And so you really need to assess these patients. The best thing we can do as clinicians is go back to the basics and think about your assessment 101 and really listen to their lungs all the way to the bases in the back. And if you hear any crackling or wheezing, that would clue you in. This patient might need a chest x-ray. I bet she's got pulmonary edema. And so that's the non-cardiogenic pulmonary edema, when we have that leaky vasculature. But then also, when you have this inability for these blood vessels to relax, and this blood pressure is so high, you have this increased vascular resistance, it's really hard for the heart to be able to overcome that pressure. And so blood can back up into the lungs, and then you have cardiogenic pulmonary edema. And so either way, you need to identify if your lungs are able to perfuse or oxygenate, and do good assessments on these patients. Other places, your brain might be a little leaky, have leaky vasculature up there. And so when we see cerebral edema, it usually presents with patients who are complaining of really bad headaches, and headaches that don't go away, and sensitivity to light. I've had patients who have complained of vision changes, or even cortical blindness. I can't see. I really can't see, or I'm having, you know, peripheral vision problems, or I'm seeing floaters. Those are really, really important symptoms to listen to. And you can't really, you know, do anything but listen to your patient and ask them, how are you able to see? Does your head hurt at all? Are you doing okay? You know, mentally, are they meditating? Check out their reflexes. Are they hyper-reflexive? Is their nervous system agitated by the amount of leakiness in their brain from this vasculature dysfunction? And so that would be another severe feature of preeclampsia. And so any of these would put the patient at higher risk for developing eclampsia. So eclampsia is where the patient actually develops seizures. And that's not good. Of course, that increases your morbidity and can increase the risk of, if she's still pregnant, abruption. So also, this isn't listed under a severe feature, but I think it's worth mentioning that the uterus also an organ. And so when you have decreased perfusion to the uterus, it affects your blood flow through the placenta, and it increases your risk of preterm delivery, abruption, fetal growth restriction. Again, if you're not able to perfuse this placenta, you're going to end up with this ischemia and microcalcifications that are not ideal for gas exchange. The placenta is ultimately the fetal lung. That's what's doing all the gas exchange during pregnancy. And when it's filled with calcifications or clots, it's not going to be able to perfuse optimally to this fetus. So a lot of times in the fetus, we'll see these babies being small. We might see changes on the fetal monitor because they're not able to compensate like a normal fetus is with a healthy placenta. So all of these things all interplay together because of the bad vasculature of preeclampsia. It's fascinating. Also, if a patient does have an abruption, that can be cataclysmic. An abruption is a pulling away of the placenta, the uterine wall, and that usually involves a lot of blood, and coagulopathies ensue quickly. And if your platelets are very low, that's going to be very, very troublesome for the fetus and for the mom. So quickly, DIC can develop. I think that's all I want to say about those. We did kind of talk about the different nomenclatures of hypertension, but HELP is super interesting. This is also part of preeclampsia, and that's the acronym. Its most common symptom is upper gastric pain and malaise in over 80%. Those two symptoms are more common than an elevated pressure in these patients. So someone who comes in just complaining of vague malaise and upper gastric pain, who had a baby 2 weeks ago, you might consider what else is going on with this patient. So the different things that accumulate to cause HELP is the hemolysis, which is there's a microangiopathic hemolytic anemia. So what does that mean? It means the red blood cells that are going through this teeny tiny vasculature that's having spasms and not remodeled. The red blood cells are actually damaged and fragmented as they go through these tiny blood vessels that have the endothelial damage and fibrin. So when you look at a blood smear, this is super interesting because I just looked at one of these recently. You'll see the red blood cells are showing schistocytes or burr cells or broken down, or helmet cells, and they can't carry oxygen anymore. So it interplays with the ability to perfuse these organs. So not only is your perfusion decreased, now you don't have the oxygen carrying capacity of a normal pregnancy to get oxygen further to these tissues and to these organs. So that's the hemolysis. The elevated liver enzymes, twice the normal limits. And again, that's due to the perfusion and leaky vasculature, and the liver is not, can get involved, and it can be very problematic, and clotting cascades can be involved in that eventually. But checking your liver enzymes and looking to see where they're at would also, lead in quickly. And then the low platelet count that we kind of mentioned. So again, the platelets are activated with the endothelial dysfunction, and they're all used up. Those platelets are trying to plug those micro tears in the vasculature, plug up those little holes in the soaker hose, and they get used up, and then they drop very quickly. So it's very problematic for patients who need them to clot. So that's HELP, and the pathway doesn't help. Now the treatment, I promised I wouldn't talk about that much. But the goal is to prevent seizures and then treat your severe pressures. Obviously treat the different symptoms, but Carrie is going to go into this with her team in April, so I'm not gonna steal anyone's thunder. But it's very easy anymore with the different algorithms that are provided that have come out. It's very standardized, and I appreciate it because I do remember as a new grad trying to take care of 2 severely preeclamptic patients, and both doctors had different recipes on how to do it. One wanted to give MAG for her blood pressures, and one wanted to give, and there's been so much education and standardization across the board that it's easier for us clinicians that we were able to provide standard care and evidence-based care that really optimizes our outcomes. So future medical implications, I did kind of mention, preeclampsia is associated with a 4-fold increase of future incidence of heart failure, a 2-fold increased risk in coronary heart disease, stroke, and death because of coronary heart disease or cardiovascular disease. And so anyone who has been diagnosed with any kind of hypertensive disorder of pregnancy really needs to be monitored closely for the rest of their lives for any of these unfortunate complications. And so really what AIM and ACOG and A1, they're all trying to work on is that handoff from 6 weeks postpartum into primary care so that, you know, women who had preeclampsia can be identified early, you know, for hypertension or, you know, signs and symptoms of heart failure and be proactively managed throughout their lifespan instead of waiting until it becomes a real problem. So I think that was my next slide. Yep, that one. Okay, I wanted to share one of the resources that I love is the Safe Motherhood Initiative. And this is ACOG's chapter in New York has been developing and implementing standard approaches for handling different obstetric emergencies. They really focus on the 5 leading causes of maternal death, which is sepsis, hemorrhage, VTE, blood clots, severe hypertension in pregnancy, blood pressure disorders of pregnancy, and cardiac conditions. So they're excellent resources. I do have the link attached on one of my next slides. One of my favorite things they have an ED checklist for postpartum preeclampsia on the next slide. And I really, you know, OB units really work with your ED units, and applause to the 11 ED units that are non-birthing hospitals, because your patients, you know, when you showed that map of Kansas initially where you're all at, our patients across the state have limited access to healthcare. And so you might be it. You might be the one who listens to this patient's lungs, listens to this patient's complaints and said, you know, she had a baby 2 weeks ago. I think she might have postpartum preeclampsia. To start with, you know, are all of your EDs, emergency departments, are you all screening even for recent pregnancy? You know, that was a big step in one of the organizations I was part of. There's so many questions that the EDs, you know, have to ask. And so asking, have you been pregnant in the last 6 weeks was like one more question. But when I talked to them about the importance of just asking, are you currently pregnant? Have you been pregnant in the last 6 weeks? Have you been pregnant in the last year? You know, if they've had a recent pregnancy, that'll include so many differential diagnoses that the clinicians wouldn't otherwise be tuned into. I mean, someone who presents 2 weeks out after they have a baby, if you don't ask them they have a baby, you know, or have had a recent baby, and their blood pressure is elevated but not severe, they have a horrible headache, what do you treat them with? And you send them home. And we see that time and time again, you know, across the United States. Patients aren't adequately identified for having preeclampsia with severe features, and they're sent home. And so complications is of course higher if they're not treated. So great resources here, signs and symptoms to look for, labs, medical management, just great checklists that are available to anybody for free. And of course you can work with clinicians in your institution to tailor it to your own institution. On the next slide, I have some, which Carrie, I'm sure will send out, a link to the Safe Motherhood Initiative they shared, AIM urgent maternal warning signs, really educating our patients when you discharge them, or even having signs up in the bathrooms of your ED. Have you had a baby in the last 6 weeks? Are you having any of these symptoms? And having pictures that patients can see, and educating our patients, you know, when they need to seek medical attention. If they don't know and they attribute it to, oh, I have a headache because I was up all night, or man, I didn't work out during pregnancy and I'm so out of shape, I'm getting short of breath just going up the stairs. If they don't know when to seek care, they're not going to. So really helping patients and partnering with patients to know who to call, when to call, is really making big strides. And then I was super excited that you guys are doing the A1 post-birth education. Again, free resources to patients, great education for our healthcare team. And you can download it. I think they have it in a number of different languages. I want to say like 15, but I haven't honestly looked lately. So great resources are out there. And I just wanted to wrap up and see if anybody had any questions. I haven't been looking at the chat or anything, but anybody have any questions about the disease process of preeclampsia or anything that strikes your fancy?
I love an opportunity for questions. So I just wanted to add on, as you were talking about the post-birth warning sign things that we learned at A1's conference in February, that it's actually, I know when we started promoting this, there were magnets and printable resources, but now it's an app that patients can have on their phone, which I think is a godsend because they have their phones everywhere. So when they shared that with us in February, I was doing cartwheels to know that that's something our facilities can tell our patients too, is this can be on your phone. You don't have to have it on your fridge or any of that. Although I think that's good for your family members or significant others to be aware as well, since they tend to see things that happen with us before we do sometimes. I'm just checking to make sure I don't see any questions in the chat. I just think I want to say thank you so much for presenting because I think it's such important information for us to hear again. Not everyone on this call are clinicians in practice. And so this could be a first for many people, but for even those of us who are at the bedside or practicing every day, you can forget all the details of why this is so important. Sometimes it becomes just say, yep, it's preeclamptic, okay, let's treat her and get it out. And you forget about all of the components that happen with this disease process that can impact her in the long term. And when we look at maternal mortality, we are changing the verbiage to ensure that we're having this conversation of asking the patient if she's been pregnant within the last year. That's because we want to identify even beyond that 6 weeks of how could this have impacted her body in the long haul. Maybe she doesn't have preeclampsia now, but maybe she has cardiomyopathy because she had a baby, 6 months ago and had preeclampsia, and et cetera, et cetera. So I just think it's a really important conversation to be having, not just because we're doing this bundle, but because, like you said, it's the number one cause of issues in our pregnant patients right now. And it's unfortunately very prevalent. You're seeing it so frequently. So thank you so much for presenting. And I will open it up again one more time just to see if anyone has any questions or comments that they wanted to add into.
And I want to say thank you for having me. This might be old news to some of you, and it might, if you take one thing away and it changes your practice or how you teach, a new nurse, then I feel like it was worth listening to. I remember, Carrie said something about back to basics and being able to take a blood pressure and really going back to the basics of, your clinical assessment, listening to the lungs, listening to the heart, listening to, feeling your patients and listing them for any kind of symptoms, taking a blood pressure correctly. I remember when we had this education about blood pressure measurements, and I know how to take a blood pressure. I've been a nurse 10 years. And then when I got out and measured my own arm, I was a low blood pressure. I just thought, how many people before we measured did I misdiagnose, or not adequately address her blood pressure because I didn't use the right cuff? It's so basic, but that's why we're starting with the basics, because we have to.
Or even the change in practice that when I first started, and we don't have to talk about how long ago that was, but it was more recent than some would think. Just the concept of treating and streeting, how you lay them on their side, recheck a pressure. It looked beautiful. Oh, I guess you can go home now. And it's like, okay, no, guys, we're not doing that anymore. If you should, you sit her upright and you check it. Yep, it's a problem. So
I know we've come a long way. We
have. Well, you guys, thank you all so much for joining us today. And again, if you haven't put your name in the chat in your facility, please do that before you jump off. And otherwise, this recording will get sent out by Tiffany tomorrow, along with the registration for post-birth. So please share that with your staff. Yeah.
It looks like Tessa may have a question.
I do.
Yay.
All right. I don't know if it applies too much to Bree's presentation, but just treating these patients in general. One area that I would love to see in our protocols that go out to the state would be the timing of delivery for that patient at diagnosis that's not with severe features. We struggle sometimes with staffing and prioritizing, which patient's more medical. Can this patient wait 12 more hours and start tomorrow instead of today, that right now this afternoon, while we don't have any nurse to take care of her? We've had our OB subsection chair try to find data for us on this, and he says it's really not very clear. It just says at 37 weeks or at diagnosis, but it doesn't mean, just now today. It used to be a range. You needed to deliver at 37 or 38 weeks. And so I would love to see more information to help us, guide us on that in the future.
That's awesome. And yeah, you're absolutely right. We know ACOG has that list of recommended delivery times per, say, per concern or per issue. But that's something we definitely can make sure that we include in our April meeting to say, let's look over that list and how have they shaped that to possibly be able to identify. Sometimes that even includes bringing in MFM to help guide that conversation more too. So great statement. And I made a note of it for April. So thanks, Tessa. Okay, everyone, have a great rest of your week. And thanks again for joining. And again, make sure you get signed up for the April in-person meeting. Have a wonderful day.